You know that sudden twinge in your back, right? Or maybe it's that nagging ache in your knee.
Or yeah, that hip discomfort that seems to come out of nowhere.
These are just incredibly common things. They can really stop you in your tracks sometimes.
Make simple things feel impossible.
Exactly. So, welcome. This is our deep dive, dedicated to understanding and navigating these common musculoskeletal pains. We're focusing specifically on your back, hips, and knees today.
Right. And our mission is pretty straightforward. We've gathered a lot of important information.
And we want to distill it, break it down, and give you the knowledge you need.
So you're well informed about what might be causing your pain, crucially, when to worry.
And what you can actually do about it. Think of this as your shortcut, really.
A way to decipher your body's signals.
So you can have those more informed conversations with your healthcare provider.
Makes a big difference.
Today, we're going to explore the surprising costs tied to back pain.
Yeah, the economic impact is huge.
We'll also get into the mechanics of your spine and your big joints of hips and knees.
And importantly, we'll highlight those critical red flags.
The signs that mean something serious might be going on. You need to know those.
Definitely. Then we'll walk through the common conditions, how doctors figure things out.
And the different ways to manage the pain. Everything from lifestyle changes to meds, even when you might need a specialist.
It's a lot to cover, but really useful stuff.
Okay, let's kick things off with the back. I saw this statistic that just blew me away.
Oh, yeah.
Direct healthcare costs for back pain. In the U.S., for example, it's over $100 billion a year.
It's staggering, isn't it? It really shows how widespread this is.
$100 billion.
And what's really striking is that people with back pain, their healthcare costs are about 60% higher than those without.
Wow. So it's a huge burden, personally, and, well, for the whole system.
Absolutely. And when we talk about the spine, especially the low back, it's quite an amazing structure.
Like how?
Well, think of it like a stack of bony blocks. Those are the vertebrae.
Okay.
And between each one, you've got these soft, cushiony discs.
The shock absorbers.
Exactly. They allow movement and absorb impact. And the vertebrae themselves form this protective tunnel.
Right, for the spinal cord.
The body's main communication cable running right down your back. It's elegantly designed.
It really is. Now, you said most back pain isn't serious, often just a strain, right?
That's right. Most of the time, it gets better on its own.
But there are these critical warning signs, these red flags you absolutely cannot ignore.
This is maybe the most important takeaway for listeners today.
What are they? What signals that it's not just a simple backache?
Okay, so the key here isn't self-diagnosis, but knowing when to seek urgent medical help, not waiting it out.
Got it.
So one big one is prolonged pain if it lasts longer than, say, 4 to 6 weeks without improving.
Okay, 4 to 6 weeks. What else?
Other specific flags include being over 50, currently using corticosteroid medications, having a fever along with the back pain,
Fever.
having had a recent procedure involving blood vessels, like an angiogram, or a history of injection drug use.
Right. Those increase infection risk.
Exactly. Also, pay attention if the pain is worse first thing in the morning, or if it wakes you up at night, or gets worse when you lie down.
That sounds different from a typical strain.
It can be. Then there are the neurological signs. Numbness or weird sensations in the perineum and buttocks area.
That saddle anesthesia you mentioned.
Yes, precisely. Or severe weakness in both legs, maybe with shooting pain down both.
Bilateral sciatica. Okay.
And any new difficulty controlling your bladder or bowels, that's a big one.
That sounds like an emergency.
It absolutely is. Also, a prior history of certain cancers, particularly prostate, breast, or multiple myeloma, which tend to spread to bone, is a major red flag.
Okay, super important list there. So we know lumbar strain is common. What else causes back pain?
Good question. Beyond strains, one condition to know is spinal stenosis.
Stenosis, narrowing right.
Exactly. The spaces in your spine narrow, putting pressure on the nerves or spinal cord.
And how does that feel?
It typically causes leg pain, maybe cramping. That comes on with walking. It gets worse if you stand up straight or lean back.
But the key is...
The key is it often improves immediately if you sit down or lean forward.
like pushing a shopping cart. I've heard that.
That's the classic example. Or walking uphill. It accounts for maybe 3% of low back pain.
Okay. What else?
Then you have inflammatory conditions, things like psoriatic arthritis.
Associated with psoriasis.
Yes, that back pain is often worse in the morning, but improves as the day goes on. You might also see swollen fingers or toes, sausage digits, nail pitting, skin changes.
Interesting.
There's also reactive arthritis. can cause tendinitis, often in the heels, sometimes linked to infections like C. diff or chlamydia.
Oh, okay.
And even inflammatory bowel disease like Crohn's or colitis can cause inflammation in the spine or the joints at the base of the spine, leading to that prolonged morning stiffness in the buttocks.
So the gut can affect the back.
It definitely can.
And what about the really serious stuff? Cancer, infections.
Right. Malignancy or cancer is a concern, especially over 50 or with that history we mentioned.
Prostate, breast, myeloma.
Yes, and infections, bone infections like osteomyelitis or abscesses near the spine.
And the risk factors you mentioned, like drug use, recent procedures.
Like recent skin infections being on immunosuppressing drugs, yeah.
Yeah.
Those raise suspicion.
Okay. And you also mentioned pain referred from other places.
Crucial point. Sometimes back pain isn't from the back at all. It could be referred pain from abdominal or pelvic issues.
Like what?
Could be an abdominal aortic aneurysm, especially in older smokers with high blood pressure, pancreatitis, peptic ulcer disease, kidney infections.
So if the back pain comes with other symptoms.
Exactly, like severe belly pain, weight loss you can't explain, changes in bowel or bladder function. You need to think beyond the spine.
Got it. And the emergency one.
Cauda equina syndrome. Severe nerve compression at the bottom of the spinal cord. Requires urgent imaging, urgent treatment.
And the signs are those red flags again.
Yes, the saddle anesthesia, bilateral leg weakness, and sciatica, bowel or bladder dysfunction. True emergency.
Okay, really clear. So someone comes in with new back pain. Do they automatically get an X-ray or an MRI? People often expect that, right?
That's such a common expectation and a really important question. Here's something that might surprise you.
Okay.
A lot of people without any back pain actually have things like bulging discs on an MRI over half, or protruding discs maybe a quarter.
Really? With no pain?
With no pain at all. They can just be normal signs of aging, like wrinkles on the inside.
Uh,
And doing imaging too early unnecessarily can sometimes lead to what we call a labeling phenomena.
Labeling phenomena.
Yeah, just knowing you have a bulging disc, even if it's not causing the pain, can sometimes make you feel more vulnerable or fragile and actually hinder recovery. It's a psychological effect.
Wow. Okay, so imaging isn't always the first step.
Definitely not. The first step is always a good history, asking about duration, those red flags we talked about, and a thorough physical exam.
Looking for fever, neurological signs.
Right. Decreased reflexes, muscle weakness, checking how you walk, feeling for tenderness along the spine.
So when is imaging useful then?
It is useful if we suspect a fracture, maybe after a fall or trauma, or in someone at risk for osteoporosis, like an older woman or someone on long-term steroids. Plain X-rays are good for that.
Okay, an MRI.
MRI is reserved for situations where we suspect something serious impacting the nerves or spinal cord, those severe or worsening neurological deficits, suspected cauda equina, a history of cancer, or if there's a fever suggesting infection.
So for most simple, acute back pain.
Generally, we recommend delaying imaging for 4 to 6 weeks if there are no red flags and no major neurological issues. Give it time to improve first.
That makes sense. So let's talk management. The old advice was just rest it off, maybe binge some TV. That's changed, hasn't it?
Oh, drastically. That old advice about strict bed rest is actually counterproductive. Yes. For acute low back pain, the first step is patient education. Understanding that, improvement is very likely within weeks, but also that recurrence is possible. Setting realistic goals for pain management is key.
And activity.
This is the big change. Avoid strict bed rest. Patients who are encouraged to gently increase their activities as they can tolerate it actually recover more quickly. Keep moving within limits.
Good to know. What about medications?
First line is often NSAIDs, non-steroidal anti-inflammatories like ibuprofen or naproxen, usually at the higher end of the dose range for maybe 7 to 10 days. Acetaminophen is another option.
And things like muscle relaxants or stronger painkillers.
Here's another important point. Muscle relaxants and narcotic opioids are generally not superior to NSAIDs for acute low back pain.
So they shouldn't be the first choice.
Definitely not. Opioids should really only be considered if non-drug therapies, first-line meds like NSAIDs, and maybe second-line options haven't worked. And even then, it requires a very careful discussion about the risks and benefits.
What about steroid injections?
Oral steroids or epidural steroid injections might offer some short-term pain relief for certain conditions like sciatica. But, and this is crucial, they generally do not impact long-term outcomes or reduce the need for surgery.
So not a magic bullet.
Far from it. And for those inflammatory conditions we mentioned, like spondyloarthritis, a rheumatologist might prescribe specialized medications like DMARDs or TNF alpha blockers.
When should someone think about physical therapy?
Physical therapy is a great option. Definitely consider it if the pain is interfering with your daily life, home, work, hobbies, or if your doctor notices issues with your posture, maybe a leg length difference or how you walk. PT can really help address underlying mechanical issues.
On surgery, when does that come into play?
Surgery is generally reserved for the serious situations as progressive neurological problems like cauda equina syndrome, definite bowel or bladder dysfunction caused by nerve compression, or absolutely intractable pain that hasn't responded to months of conservative treatment.
So it's a last resort for most people.
For most types of back pain, yes. The decision for surgery is complex and needs very careful consideration between the patient and the surgeon. The overall guideline now really emphasizes trying non-drug therapies, first things like staying active, heat, maybe PT, before even starting medications for most acute, subacute, or chronic back pain.
Okay, that's a really comprehensive look at back pain. Let's pivot now. We've dissected the back. But what about when the ache is lower down in the hip? Why is hip pain sometimes so, well, tricky to diagnose? It feels like it could be coming from anywhere sometimes.
It really does. Hip pain can be a real chameleon. And what's fascinating, like you said, is that what someone feels as hip pain often doesn't actually originate from the hip joint itself.
So where else could it be coming from?
You might feel pain deep in the groin, maybe in the buttock, or it might even radiate down the thigh or towards the knee, even if the problem isn't the hip joint.
Okay, so anatomically, what is the hip joint?
It's a classic ball and socket joint,
Mhm.
very strong. The ball is the head of your thigh bone, the femur. And the socket is a cup-shaped area in your pelvis called the acetabulum. It's designed for stability and a wide range of motion.
And you mentioned bursae earlier.
Yes, surrounding the joint are these small fluid-filled sacs called bursae. They act like little cushions to reduce friction between tendons, muscles, and bones. There are several important ones around the hip.
And hip pain is common too.
Very common, especially as we age. Over 14% of U.S. adults over 60 report hip pain. Interestingly, while women tend to report more symptoms,
Yeah.
men actually tend to have more X-ray evidence of osteoarthritis in the hip.
Huh, that's odd.
It is. And here's a really crucial point. X-ray findings and symptoms often don't match up perfectly.
What do you mean?
Only about a third of people who complain of hip pain actually have significant osteoarthritis visible on an X-ray. So your symptoms, how you feel, are often much more important for diagnosis than the X-ray itself, especially early on.
That's incredibly insightful. So how do doctors start to figure out if it's the joint itself or something else?
That's the fundamental question. Is it articular, meaning coming from within the joint, or extra-articular, meaning from structures around the joint, or referred from elsewhere?
Okay, articular first. What causes pain inside the hip joint?
By far the most common is degenerative arthritis, or osteoarthritis, OA. That's the wear and tear type.
Right.
Inflammatory arthritis, like rheumatoid arthritis, can also affect the hip. Other causes include a hip fracture, obviously, or a joint infection, septic arthritis,
Okay.
and a condition called a vascular necrosis, where the bone tissue actually dies due to lack of blood supply. This can sometimes be linked to long-term corticosteroid use, lupus, sickle cell disease, or heavy alcohol consumption, and rarely cancer that is spread to the bone.
Got it. And extra-articular. Pain from outside the joint.
Lots of possibilities here. Bursitis inflammation of those sacs is very common. Trochanteric bursitis on the side of the hip is a big one. Also tendinitis, inflammation of the tendons. Nerve issues like sciatica radiating from the back, or a specific nerve irritation called neuralgia paresthetica. Even conditions like polymyalgia rheumatica, or vascular problems causing claudication, or issues in the abdomen.
So when a patient comes in, how does the location of their pain help you narrow it down?
Location is a huge clue. If the pain is deep in the groin or the front of the hip,
Yeah.
that often points towards the hip joint itself, articular causes. But it could also be things like an inguinal hernia, iliopsoas bursitis near the front, maybe even kidney stones or vascular issues.
Okay. What if it's on the side of the hip?
Pain on the lateral side, the outside, very commonly suggests trochanteric bursitis or maybe tendinitis there. But it could also be referred pain from the lower back or that neuralgia paresthetica we mentioned.
And buttock pain.
Buttock pain can be tricky. It could be the hip joint, but it's also very commonly referred from the lower back, or maybe ischial bursitis, pain when sitting, piriformis syndrome, or even vascular problems.
So location helps, but isn't definitive. What about the pattern of the pain when it hurts?
The pattern is also very telling. Think about inflammatory conditions like rheumatoid arthritis.
Okay.
They typically cause significant morning stiffness, often lasting more than an hour, but the pain actually improves with activity as the day goes on.
Ah, okay. And osteoarthritis.
Degenerative arthritis, OA, is usually the opposite. It tends to feel better with rest, but gets worse with activity and towards the end of the day. Stiffness after sitting is usually brief, less than 30 minutes.
And if it's worse with activity, but better immediately with rest.
That pattern might make you think about vascular insufficiency problems with blood flow.
Got it. So history is key. What about the physical exam for hip pain? What clues do you look for?
The exam starts just by watching you walk. A limp, what we call an antalgic gait, is really common with hip OA as you try to spend less time putting weight on that painful side.
Makes sense.
Then we check range of motion. And here's a key finding. With hip joint disease, internal rotation, turning the leg inward, and abduction, moving the leg out to the side, are often the first and most significantly affected movements.
Interesting. Early signs.
Yes. Then there are specific tests. The Patrick's or Faber test involves positioning your leg in a sort of figure-4 position. If that causes pain in the groin, it strongly suggests an issue within the hip joint.
Okay.
A straight leg raise test helps check for nerve irritation coming from the back, ruling out referred pain. And the Trendelenburg test looks at the strength of the hip abductor muscles on the side.
Okay, let's talk about some of the specific hip disorders now. Osteoarthritis seems like the big one.
It really is. Osteoarthritis of the hip typically has a gradual onset. Deep groin pain is the most common symptom, but it can radiate down towards the knee.
And worse with activity.
Yes, worse with weight bearing. People often mention difficulty with things like tying their shoes or having to go upstairs sideways. The stiffness after rest, like we said, is usually brief, less than 30 minutes.
And treatment. You mentioned non-drug things first.
Absolutely. For hip OA, the strongest recommendations are for non-pharmacologic approaches first. Exercise, like strengthening, flexibility, aerobic, weight loss if appropriate. Tai Chi has good evidence using assistive devices like a cane if needed.
And if that's not enough?
Then we consider medications, topical NSAIDs or oral NSAIDs. Intra-articular glucocorticoid injections, steroid shots right into the joint, can provide temporary relief.
What about things people often ask about, like glucosamine or stem cells?
Great question. For hip OA, the guidelines strongly recommend against using non-tramadol opioids. They also strongly recommend against glucosamine and chondroitin sulfate supplements. The evidence just isn't there for hip OA. Same for stem cell injections and platelet-rich plasma, PRP, not recommended due to lack of proven benefit and potential cost.
Good to know. You mentioned bursitis earlier, too, trochanteric bursitis.
Yes, trochanteric bursitis is very common. It causes a deep ache or pain right on the bony point on the outside of your hip, the greater trochanter, sometimes radiating down the outer thigh.
Worse with?
Worse with walking, squatting, climbing stairs, or lying on that side at night. You'll feel distinct tenderness right over that bony spot. It's more common in women, often in their 40s to 60s.
And treatment for that?
Usually involves rest from aggravating activities, NSAIDs, stretching. Corticosteroid injections into the bursa itself can be very effective, often providing long-term relief.
Okay. What about the buttock pain bursitis?
That's likely ischiogluteal bursitis, sometimes called Weaver's bottom, because it affects the bursa over the ischial tuberosity, your sit bone.
Oh.
So the pain is in the buttock, and it's typically worse when sitting, especially on hard surfaces or sometimes lying down. You'll find tenderness right over that sit bone.
Makes sense. Treatment?
Using cushions when sitting is key. Gentle stretching, like pulling your knee towards your chest, can help. NSAIDs. And again, a corticosteroid injection can be very helpful if conservative measures fail.
And the last one you mentioned was neuralgia paresthetica. Sounds complicated.
It sounds fancy, but it's actually just irritation of a specific nerve, the lateral femoral cutaneous nerve, which supplies sensation to the skin on the front and outer part of your thigh.
So what does it feel like?
It causes dysesthesia, weird sensations like numbness, tingling, burning, sometimes coldness, specifically on that anterolateral thigh area. Importantly, it's purely sensory. There's no muscle weakness, and the symptoms don't go below the knee.
And what causes the nerve irritation?
Often it's compression of the nerve as it passes near the groin under the inguinal ligament. Risk factors include obesity, pregnancy, wearing tight belts or waistbands, sometimes diabetes.
And the church.
Primarily aimed at reducing the pressure, so avoiding tight clothing or belts, weight loss if applicable. NSAIDs might help with inflammation. Sometimes local nerve blocks or corticosteroid injections near the nerve can provide relief. It usually gets better on its own over time.
Okay, that covers the hip pretty well. Let's move down to the knee now. The body's largest joint, right, and notoriously complex.
It absolutely is. The knee does an incredible amount of work, bearing load, providing stability, allowing movement. It's a hinge joint primarily, but with some rotation too.
So break down the anatomy for us simply.
Okay, you've basically got two main joint surfaces. The tibiofemoral joint, where your thigh bone femur meets your shin bone, tibia,
Right.
and the patellofemoral joint, where your kneecap, patella, glides in a groove on the femur.
Got it. And it's held together by...
Strong ligaments. You have the collateral ligaments on the sides, medial and lateral, outer, providing side-to-side stability.
MCL, LCL.
Exactly. And then inside the joint, you have the cruciate ligaments, the anterior ACL and posterior PCL, which cross over and control front-to-back motion and rotation.
Okay. And the menisci.
Those are two C-shaped pieces of tough cartilage, the medial and lateral menisci that sit between the femur and tibia. They act as shock absorbers and help with stability and fit.
Like cushions.
Precisely. And like the hip, the knee also has several bursae around it to reduce friction.
Okay, so complex structure. When someone comes in with knee pain, what are the key things you ask about in their history?
Age is a big initial clue. In younger adults, knee pain is often related to an injury, maybe a torn meniscus or ligament from sports, or overuse syndromes like tendonitis or bursitis.
In older adults.
In older individuals, degenerative conditions, especially osteoarthritis, become much more common.
Makes sense. What about the specifics of an injury?
How the injury happened is crucial. Did they hear or feel a distinct pop?
What does that suggest?
A pop often signals a torn ligament, especially the ACL. Also, the timing and type of swelling is important.
How so?
Swelling that comes on very quickly, within an hour or so. That usually means hemarthrosis blood inside the joint, which points to a significant injury, like an ACL tear or fracture involving the joint.
And slower swelling.
Swelling that develops more gradually over several hours or the next day is more likely an inflammatory effusion, just excess joint fluid, which can happen with meniscus tears or arthritis flare-ups.
What about feelings of instability?
A feeling of the knee giving out or buckling, or experiencing episodes where the knee feels locked and won't straighten. Those strongly suggest a significant ligament injury or possibly a torn meniscus fragment getting caught in the joint.
And that rapid onset pain you mentioned earlier.
Yes, if someone develops intense warmth, redness, swelling, and severe touch-me-not pain over just 24 to 72 hours, you have to strongly suspect crystalline arthritis, like gout or pseudogout, or even a joint infection.
Okay, lots of clues in the history. What about the physical exam for the knee?
First, we watch you walk looking for limp alignment issues like bow legs or knock knees. We look for obvious swelling patterns. Is it diffuse within the joint or localized over bursa? Any muscle atrophy, especially in the quadriceps.
And feeling the knee.
Palpation is key. We check the temperature. Believe it or not, a normal knee should feel slightly cooler than the surrounding skin. Warmth suggests inflammation. We check for fluid. A bulge sign can detect small amounts of fluid, while a palatable patella, where the kneecap feels like it's floating, indicates a large effusion. We also feel carefully for specific areas of tenderness, like along the joint lines or over tendons and ligaments.
And then the specific tests for ligaments and meniscus.
Exactly. There are several specialized maneuvers. For the ACL, we use tests like the Lachman test and the anterior drawer test to check for forward looseness of the tibia. The pivot shift test assesses rotational stability.
Okay. And the PCL.
For the PCL, the main test is the posterior drawer test, looking for backward sagging of the tibia.
And the meniscus. How do you check for tears?
The McMurray test is a common one. We bend, straighten, and rotate the knee while feeling the joint line. A click, pop, or pain during this maneuver can indicate a torn meniscus. Difficulty fully extending the knee can also be a sign.
Okay, let's dive into some common knee disorders, starting again with osteoarthritis.
Osteoarthritis of the knee is extremely common. Like we said, about 6% of adults over 30, maybe 12% over 65.
Similar pattern to the hip.
Very similar. Gradual onset. Pain is typically worse with use, especially weight-bearing activities like walking or stairs, and better with rest. Often worse at the end of the day.
And the stiffness.
Stiffness after periods of inactivity, that gelling phenomenon, but it usually lasts less than 15 or 30 minutes, shorter than inflammatory arthritis.
What might you see on exam?
You might notice some bony enlargement around the knee, maybe some wasting of the quadriceps muscle, tenderness along the joint lines, and often a coarse crackling or grinding sensation called crepitus with movement.
Treatment similar to the hip too.
Yes, the approach is very similar. Strong emphasis on non-pharmacologic first, exercise, aquatic therapy, strengthening, aerobic, weight loss, maybe bracing or assistive devices.
Then meds.
Then NSAIDs, topical or oral, acetaminophen. Intra-articular corticosteroid injections can provide temporary relief. What about glucosamine and chondroitin for the knee? The evidence is a bit more conflicting than for the hip. Some guidelines say you could try it for maybe 3 months, but if there's no clear benefit, stop it.
And knee scopes for arthritis.
That's important. For just osteoarthritis, arthroscopic surgery to simply wash out the joint, lavage, or shave down cartilage, debridement, is generally not recommended. The evidence shows it's not better than placebo or physical therapy unless there are specific mechanical symptoms like locking due to a loose body or a complex meniscus tear causing locking.
Good clarification.
Yeah.
What about those inflammatory or infectious causes in the knee, gout?
Right. The knee is actually one of the most common joints affected by gout. It presents classically. Sudden, severe onset of pain, redness, warmth, swelling, often reaches peak intensity within 24-48 hours. It's excruciating.
And diagnosis.
Definitive diagnosis requires arthrocentesis, drawing fluid from the joint with a needle and examining it under a special microscope. You look for those characteristic needle-shaped, negatively birefringent monosodium urate crystals.
And pseudogout.
Pseudogout, or CPPD, can look very similar to gout acute inflammation, but it often doesn't involve the big toe. Podagra is classic for gout, and the episodes might linger a bit longer, sometimes weeks.
Diagnosis also by fluid.
Yes, definitive diagnosis is also by arthrocentesis, but here you find different crystals. Typically rod-shaped or rhomboid-shaped, weakly, positively birefringent calcium pyrophosphate crystals.
And septic arthritis, the infection.
Septic arthritis is a true orthopedic emergency. The knee is the most common joint involved, about 50% of cases. Intense pain, heat, redness, swelling, significantly reduced range of motion. Often the person feels systemically unwell with fever, chills, elevated white blood cell count.
Most common bug.
Staphylococcus aureus is the most frequent culprit. Diagnosis requires urgent arthrocentesis to analyze the fluid for bacteria and white blood cells, and treatment involves prompt drainage of the joint and aggressive intravenous antibiotics. You don't want to miss this.
Definitely sounds urgent.
Yeah.
Okay, shifting to injuries. Ligaments and menisci.
Right. Meniscus tears are very common, especially the medial meniscus because it's less mobile. Often happens with twisting injuries on a planted foot.
What does it feel like?
Can cause pain, swelling, sometimes a clicking or popping sensation. A specific type called a bucket handle tear can actually flip into the joint and cause the knee to lock up, preventing full extension. The hallmark on exam is tenderness right along the joint line.
And the cruciate ligaments, ACL, PCL.
ACL injuries are common in sports involving pivoting, cutting, or sudden stops, often associated with that audible pop at the time of injury, rapid swelling, hemarthrosis, and a feeling of the knee buckling or giving way.
And the PCL.
PCL injuries are less common, often occur from a direct blow to the front of the bent knee, like hitting the dashboard in a car accident. They're typically less symptomatic than ACL tears initially, maybe just some posterior knee pain or mild instability.
Okay. What about that pain around the kneecap? You mentioned runner's knee.
Right, that often falls under the umbrella of patellofemoral pain syndrome, PFPS. It's a common cause of diffuse aching pain felt around or behind the kneecap.
Worse with.
Typically worse with activities that load the patellofemoral joint, running, jumping, climbing stairs, especially going down, squatting. Also, the classic moviegoer sign, pain after sitting with the knees bent for a prolonged period.
What do you find on exam?
Often tenderness around the edges of the patella, maybe some crepitus grinding when bending the knee. Quadriceps weakness or tightness can contribute.
Treatment.
Focuses on modifying activities to avoid triggering pain, sometimes short-term NSAIDs. The cornerstone is often physical therapy, particularly exercises to strengthen the quadriceps muscles, especially the VMO, vastus medialis oblique, and improve flexibility.
And tendinitis. Jumper's knee.
Patellar tendinitis, or jumper's knee, is inflammation of the patellar tendon right below the kneecap. Causes very localized anterior knee pain with point tenderness right at the bottom tip of the patella. Worse with activities like squatting, jumping, or sometimes just walking.
Another runner's knee type.
Yes, iliotibial, IT band syndrome, is another common overuse injury, often called runner's knee. It causes pain on the lateral outer side of the knee.
worse with running?
Typically worse during or after running or cycling. The pain is usually felt over the lateral femoral condyle, that bony prominence on the outer side of the thigh bone just above the knee joint where the IT band rubs. Tenderness is usually right over that spot.
Okay. And finally, bursitis around the knee.
Yes, several bursae can get inflamed. Prepatellar bursitis is inflammation of the bursa right on top of the kneecap, often called housemaid's knee or carpet layer's knee, because it results from recurrent friction or pressure from kneeling.
Looks like.
Painful swelling right on the front of the knee, often with warmth, redness, and tenderness, needs to be distinguished from swelling inside the joint.
And anserine bursitis.
Anserine bursitis affects a bursa located on the intermedial side of the knee, just below the joint line, where several tendons attach. Causes pain and tenderness in that specific area, often seen in runners, swimmers, especially breaststroke, or people with knee OA.
Wow. We've covered a huge amount of ground today. Back, hips, knees.
We really have, from the spine down to the knee.
And I think the biggest takeaway for everyone listening is that really understanding the type of pain you have, where it is, and what other symptoms come with it, especially those critical red flags, provides incredibly vital clues.
It absolutely does.
This knowledge really empowers you, doesn't it, to have much more informed, much more productive conversations with your doctor or physical therapist.
Exactly. You move beyond just saying, my back hurts or my knee hurts.
Right. You can actually help guide the diagnosis and the treatment plan. You become an active participant.
Precisely. Being able to describe the pain's quality, is it sharp, dull, burning? What makes it better? What makes it worse? Where exactly does it feel like it's coming from? That transforms pain from just a vague complaint into really useful, actionable information.
Helps everyone work together more effectively.
Without a doubt.
So as you go about your day, maybe walking, sitting, bending, here's something to think about. How might having this deeper understanding of your body's mechanics, how these joints in your spine actually work, shift how you approach your daily activities? Could it help you prevent some of these future aches and pains before they even start?